So now we are starting our first session of Best Urology. We have our first speaker, Dr. Young, and the title of his presentation is Changes of Lower Urinary Tract Function After a Robotic-Assisted Radical Prostatectomy, a Urodynamic Follow-Up Within 1 Year. And this abstract has got the Best in Category prize. Dr. Young is here.
Thank you, moderators. Good morning, ladies and gentlemen. It's my great honor to be here to present this topic. In recent years, more localized prostate cancer patients receive the surgery of robotic-assisted radical prostatectomy, called RARP, and post-prostatectomy incontinence, called PPI, is a bothersome and common complication with a negative impact on quality of life. However, the urodynamic investigation of the lower urinary tract function after the surgery is limited. So the end of this study is to investigate the changes of lower urinary tract function in prostate cancer patients after the surgery. We prospectively enrolled 66 localized prostate cancer patients undergoing the surgery. The surgery was performed by a single surgeon. An IPSA symptom score, VUDS, and continence status at baseline were investigated at baseline and during the first year. And routinely, pelvic floor muscle training instruction was provided until the continence was achieved. Result: the mean age was 69 years old with a mean prostate volume 35.2 ml. Total 39% patients received neurovascular bundle preservation and 25% patients received postoperative adjuvant radiotherapy. After the surgery, the voiding symptoms improved within the first year. How it reflected the effect of prostatectomy and the reduction of bladder outlet resistance after the surgery. However, the storage symptoms progressed at the first months, but improved and were returned to baseline with time. It reflected that tissue inflammation after the surgery might also cause the bladder irritative symptoms in the beginning, and the inflammation would subside with time. In summary, the IPSS score decreased at 1 year. Here are the VUDS data. At 1 year after the surgery, increased bladder compliance, decreased detrusor voiding pressure, increased maximum flow rate, and decreased bladder outlet obstruction index were noted. Between the patient with and without bladder outlet obstruction before the surgery, the changes of the VUDS parameters are different. The patients with preoperative bladder outlet obstruction had more decreased detrusor pressure and more decreased bladder outlet obstruction index in compared with those without bladder outlet obstruction. In general, the patient without bladder outlet obstruction before the surgery did not have the significant changes of VUDS parameters except the decreased detrusor voiding pressure. The de novo detrusor overactivity was noted in 30.8% of the patient, and the remission rate of detrusor overactivity was 15.8%. After the surgery, immediately after the surgery, 51.5% of patients had stress incontinence and 36.4% of patients had urge incontinence. And both stress incontinence and urge incontinence improved with time, and the main recovery of the urinary continence was noted during the first 6 months. At 1 year after surgery, the stress incontinence rate was 9.8%, and the urge incontinence rate was 5.9%. After subgroup analysis, enlarged prostate volume, preoperative bladder outlet obstruction, neurovascular bundle sacrification, and postoperative radiotherapy had negative impacts on the recovery of urinary continence. On univariate logistic regression analysis, enlarged prostate volume and preoperative bladder outlet obstruction are the predictors of stress incontinence at 1 month. However, only enlarged prostate volume was the independent predictor. In addition, enlarged prostate volume was the predictor of stress incontinence at 3 months, at 6 months, and 12 months after the surgery. Discussion. Male continence mechanism included prostate gland, urethral sphincteric mechanism, and urethral supportive mechanisms. So, to avoid excessive damage and to preserve more urethral length and bladder neck structure are important to the residual urethral sphincter mechanism after the surgery. And to preserve ligament and endopelvic fascia and the reconstruction method contributed to the residual urethral supportive mechanism after the surgery. In general, after radical prostatectomy, the residual function of the urethral sphincteric and supportive systems determine the continence status. There are many reported predictors of post-prostatectomy incontinence. But in these studies, increased prostate volume, preoperative bladder outlet obstruction, neurovascular bundle saccharification, and adjuvant radiotherapy are the factors affecting the recovery of urinary continence. But only the increased prostate volume was the independent predictor of the stress incontinence after surgery. It suggested that with the advancement of technique in robotic surgery, the impact of most of these factors decreased, except large prostate volume. The evidence about the postoperative urodynamics on PPI patients is limited. And this study showed the decreased detrusor pressure, increased maximum flow rate, and decreased bladder outlet obstruction index. This finding reflected the reduction of the bladder outlet resistance after the surgery. And the de novo detrusor overactivity was also noted, and it is probably due to the bladder inflammation and alternate structure at the surgery. And the remission rate of detrusor overactivity was around 15%. And the possible reason is that some detrusor overactivity might resolve when bladder outlet obstruction is reduced. Conclusion: within the first year after the surgery, after robotic-assisted radical prostatectomy, lower urinary tract symptom and lower urinary tract function change with time, especially in the patient with preoperative bladder outlet obstruction. And stress incontinence and urge incontinence both improved with time after the surgery. And the key phase of the urinary continence recovery was the first 6 months. Enlarged prostate volume was the independent risk factor of stress incontinence after the surgery. Thanks for your attention.
Any question for Dr. John? Okay, I have a question. Dr. John, you mentioned that the prostate volume was the main problem for the outcome of continence. Do you have any idea about the critical volume after which you will say that the continence mechanism will not be that good after the surgery?
Pardon?
You have a critical volume for the prostate after which you feel that this will be a difficult outcome.
Yeah. In our study, we said the cutoff point was the 40 milliliter. Yeah, before the surgery. So, but actually, I think that nowadays in our studies, the enlarged prostate volume is a very important factor. But I think that in the past and now in the future, the cutoff volume and the factor was not the same, because with the advancement of the surgical techniques, I think that the factors before were not the important factor in the future. I think that the robotic surgery will reduce the impact of the factors affecting prostatectomy incontinence. Yeah.
Can I ask you, Dr. Yang, what is the reason behind that you propose bladder inflammation as a cause of de novo detrusor overactivity?
Do you mean the de novo detrusor overactivity, right?
I mean, why do you propose bladder inflammation as a cause?
Yeah, actually, because actually, in overall patients, we didn't see the significant change of the prevalence of detrusor overactivity. But actually, in some patients, after the surgery, the bothersome story symptoms by detrusor overactivity before the surgery diminished after the surgery. I think that in some patients, the detrusor overactivity was probably by the inflammation of the prostate, by the obstruction from the prostate. I think that after the removal of the prostate and the detrusor overactivity will remiss. I think that to mention the, I think that although the surgery is to remove the, I think that although the surgery is to remove the prostate gland, which affect the bladder outlet, but it may affect the bladder function, and this is the usually easy to be ignored. Yeah.
Yes, we have a question from Peter.
Utrecht, Netherlands. Here I am. Peter is here from Utrecht, Netherlands. Dr. Young, with regard to the questions and jumping to, let's say, clinical limits and explanation of causation, you decided to do a study retrospective in a selected group of patients, 66 number. And what was your pre-specified outcome in this group? What did you calculate you could statistically reliably get out of a group of 66 patients? What was your intention to do the statistics?
Yeah, actually,
what was your research question?
In this study, we prospectively enrolled the patient.
Yeah, sure.
Yeah, actually, we did not.
You collected the data and then you decided to do statistics.
Just
for what purpose? What was the aim of your study?
The end of actually, we want to understand the actual change of the lower urinary tract function, and actually, we did not.
What was the primary outcome of your understanding of lower urinary tract function?
Initially, we just want to understand more about the change of lower urinary tract function after the surgery.
So this type of outcome, Mr. Chairman, gives a very high chance of just accidental p-value. I'm sorry, but you find p-values and then you start concluding without pre-specified statistic questions, you will get any association that you can have. And it's underpowered for every conclusion. I'm sorry.
But actually, for a surgeon to examine the surgical outcome is very important. And although we did not calculate the power, the patient number, but it is more important to examine your surgical outcome, to examine the actual condition it happened after the surgery. So I think that although it is not very scientific to fit the criteria of the number of enrolled patient to calculate the power, to find the actual primary endpoint, but it is quite important to examine the surgeon outcome, the surgical outcome from the surgery.
I think Peter, they tried to have something complementary.
I would agree with that you are limited by numbers. Yeah, thank you.
Okay, thank you very much.
Thank you very much, Dr. Young. Thank you.